a great privilege to introduce Amber Proctor. In my clinic, she's reduced a tremendous amount of suffering, as much as any of our most effective agents, through intelligent and compassionate use of supportive care maneuvers, and she's now going to share some of that expertise with us.
Great, thank you for having me. Sorry, I have to make it for a short person. So I am very excited to be here. I know Dr. Weiss and Dr. Hagel have talked a lot about the therapeutic interventions that we're taking and developing for squamous cell lung cancer. And I'd like to kind of focus a little bit now on the supportive care aspects of squamous cell lung cancer. And this is something that's near and dear to my heart, and I think it's important to patients as well. Importantly, there's actually data specifically in lung cancer that says if we can prioritize things like supportive care, which we sometimes will call palliative care, and oftentimes when people hear the term palliative care, sometimes they think of hospice care, which is end-of-life care. And those terms are often confused. So palliative care really means focusing on the symptoms of the patient and not necessarily going gung-ho with something that's going to have curative intent. So you can be receiving a medication to try and cure your cancer, but you can also be receiving something like palliative care to really help focus on your symptoms. And now today I'm going to focus on the symptoms of pain and anorexia and also management of side effects of treatment. But palliative care really encompasses more than just pain and anorexia. It also encompasses things like anxiety and depression. It encompasses things like having someone to talk about treatment decisions with and getting in order what your priorities are for treatment so that you're able to talk about that with your physician and your care team. And so in lung cancer specifically, there's actually good data to support the idea that if we incorporate palliative care early in your treatment, those patients actually live longer. And so the treatment that you get is important, but the supportive care aspect or palliative care aspect can also help make sure that you live longer and also enjoy a quality of life while you're undergoing treatment for lung cancer. So pain management is the first thing I'm going to talk about. And for patients with lung cancer, regardless of what treatment you're getting, you may or may not have pain. So in general, any patient with cancer, greater than 50% of those patients are going to have some sort of pain. And with cancer, it can be related to a number of things. It can be related to the tumor location in general. So some patients may actually present with pain due to the location of their tumor in the lungs. But pain can also be related to treatment. So some patients who have lung cancer may have undergone surgery or maybe a biopsy that's causing pain. They can receive radiation, which can lead to pain. And then also, some of our chemotherapies and medications that we use to treat cancer can cause certain types of pain. And so it can be multifactorial. And so when we're managing pain in the clinic, it's very patient-specific. And so it really is a discussion between the care provider and you, the patient, about where is the pain, what's the quality of pain, what makes it worse or better. And we take all that into account when we're figuring out how best to treat pain. I also have on here goals of pain management because I feel like that's really important, especially in cancer. And so pain is not a comfortable situation for anyone. And we have pain medication that can help alleviate that. But unfortunately, our pain medications oftentimes will not make the tumor go away, or they will not make it so we can stop the radiation. And so sometimes, as difficult as it is, we cannot get your pain score down to a 0 or get you back to feeling as well as you did before you started treatment. And so I think it's really important, too, when you're talking about pain with your care provider, to set good goals. And usually I focus on functional goals. So I ask questions like, what is it that you want to do during the day that you can't do now? And how can controlling your pain help you do that? And so I think that's important. And that's important because all of the pain medications that we have are going to cause side effects. And so when we're giving any sort of medication, whether it's treatment for your cancer, treatment for your pain, we're always playing this kind of balancing game between the risk of having side effects and how well the medication we're choosing is actually going to do what we want it to do. And so again, I like to talk about the goals of pain management because our goal is really to improve quality of life and improve function while minimizing the side effects of these pain medications. And so just an important thing to think about and to talk about with your care team, make sure you're setting reasonable goals when you're talking about pain management. So I have this slide just because I know I was supposed to try and fit all of this into 10 minutes, and I could talk about it for like 3 days, so I was trying to rein myself in. Because as a pharmacist, I could talk to you about medications forever, and you would be very bored. But so I have this, and I kind of think of it as a pain ladder, and I use this when when we're seeing patients in clinic, and I'm trying to figure out what pain medicines are most appropriate to treat pain. And so usually if we have someone who has mild pain, which most of us have experienced, regardless of if we have cancer or not, we can use things like NSAIDs, which are non-steroidal anti-inflammatory drugs, a lot of which are available over the counter. Those are things like ibuprofen and naproxen, which you may know as Motrin and Aleve, and also things like Tylenol to help with the pain. Now, these agents sometimes, I know a lot of new treatments were discussed today, but we still do use a lot of chemotherapy in our lung cancer patients. And so there are some drug interactions that I worry about with chemotherapy, specifically with NSAIDs and Tylenol. Things like they block a fever, and oftentimes my patients on chemotherapy, I'd like to know if they have a fever. Also things like increased risk of bleeding, increased risk of kidney dysfunctions with the NSAIDs, and so again, even in this mild pain category, when I'm trying to pick a medicine, there are cases where you still have to play that balancing game between risks and benefits. And so sometimes, even in patients with mild pain, I have to use some of these other agents that I'm going to talk about because I'm also weighing what treatment you're getting for your cancer. I want you to be successful there, and I don't want to cause any additional side effects by starting some of these medications. But they are an option in certain patients. And I'm going to talk about adjuvant therapy at the end, but you'll notice it's on every single ring of my, or step in my progression. After that, so in patients who have more moderate pain, so moderate pain is really pain that's going to interfere with some of your daily functions. And in those patients, I'll start to consider weak opioids, which is a class of medication. So those are drugs like tramadol, like codeine, like hydrocodone, or oxycodone. Now, some of my patients hear some of these drug names, like oxycodone and hydrocodone, and that makes them a little bit uncomfortable because these drugs tend to be in the news for not so good reasons sometimes. And so I usually talk, and I'm going to talk a little bit now, about our use of opioid pain medications in the treatment of cancer. Because sometimes we do need to use these medications in order to adequately control pain and make sure that patients are able to do the activities that they want to do. And I always present it kind of like this. So in cancer, you may have real pain that's due to real issues. Patients who are using some of these opioids like oxycodone, you can see fentanyl patches here on the nest ring. Patients who are abusing those and where you see those in the news are not using those medications to treat real pain. They're really using those medications for other reasons. And so these opioid pain medications were really developed for patients who have pain just like our cancer patients. And so I really see very, very low levels of addiction and abuse in our cancer patients because we're using the medications appropriately to treat real pain. And so I always bring that up because I think for most people, myself included, if you listen to the news, a lot of these drugs come up and are discussed in a negative light because they're being abused by people who are not using them appropriately. But that's why you have your pharmacist, that's why you have your physician, and I just want to remind you that this is really what these medications were made to treat. This is how they were intended to be used. And so these opioids tend to be shorter acting that will start for moderate pain. So those you would be taking multiple times a day, sort of as needed, so if you had pain. So say, for example, you were someone who had some pain, you needed to go grocery shopping, and it was hard for you to get around at the grocery store, you could utilize your pain medication for something like that so you'd be able to carry out that sort of function. And then for more severe pain, that tends to become what we call chronic pain. So patients who maybe they have pain due to tumor location or due to a surgery and it's not really healing or going away very quickly, we sometimes need to start longer-acting opioid medications, things like long-acting morphine or fentanyl or Duragesic patches. And what that does is it gives them a basal level of pain control so that they're not having to take something every 4 hours. They're not having to continuously be taking pain medicine. We're allowing them to take something 1 or 2 times a day, and then they're getting some pain control for the majority of the day. They're able to carry out, do the things that they want to do. So I also have on there what I call adjuvant medication. And I think I have this slide, yeah. So adjuvant medication is really medicine that maybe was not initially thought of as pain medicine. So it's, direct use is not to directly control the pain, but they're medicines that were initially developed or thought of to treat other conditions that we found have efficacy in treating pain. And usually we use them in addition to the other agents I talked about on the first slide, and they tend to help with certain types of pain, things like nerve pain, where I can give you some of these, the medicines I mentioned previously, but things like nerve pain that's burning or shooting, sometimes some of these other adjuvant medications are really good at helping control that, and it minimizes the amount of the other pain medicine that you need to take. And so I have classes listed on here, because this is another scary thing for patients. Sometimes I will start them on one of these adjuvant agents, and they go to Google, and they will Google that medicine, and it comes up as a depression medicine. And then they'll call me back and say, why did you start me on a depression medicine? I don't have depression. And so that's why I mentioned these antidepressants. Sometimes we use them in low doses to help with things like pain. Same thing goes with some anti-anxiety medication. So an example of that is like duloxetine or Cymbalta is actually recommended and there's data in cancer patients that it helps with chemotherapy-induced neuropathy. Again, initially designed as an anti-anxiety medicine, but what we found is that it actually helps a lot with this cancer-related pain. And then we also see anti-seizure medications used. Again, usually the doses are a little bit different than what we'd use if we were treating seizures, but they are helpful. And I kind of already talked about the last point on this slide, addiction in cancer. Again, so this is just a definition of addiction that I have. So addiction is the dependence on the regular use of a substance to satisfy physical, emotional, and psychological needs despite harm. So again, in most of my cancer patients, they have legitimate pain. They're not taking the medication and causing harm to themselves. They're taking it to improve quality of life and improve function. So sort of the next topic quickly that we wanted to touch on is anorexia. And so a lot of people think of anorexia and they think of there's also a psychiatric disorder with anorexia, but in cancer patients, anorexia can really just be a loss of appetite or a loss of a desire to eat. And that can occur even before a diagnosis is made in some patients and can be a presenting symptom before they're diagnosed. It can also be a side effect of treatment that we give patients. So some of our treatments can actually cause a loss of appetite. So I have up here the lung cancer itself, some of our treatments. Other issues that can cause either difficulty or loss of desire to eat is oral thrush, which can be caused by some of our chemotherapies and treatment modalities. That can make it difficult to eat and chew and swallow. Dry mouth or mouth sores can make eating difficult. Nausea, vomiting, or constipation can also cause someone to decrease or lose their appetite. And then things like depression and pain. And so all of these causes, right, we're going to try and treat, right? We're going to try and treat the lung cancer itself. We're going to try and treat the thrush if someone has anorexia. We're going to try and treat nausea, vomiting, and constipation. But sometimes, even if we treat all of those things and think we have them under control, anorexia can still be an issue. And so I do have some medications up here that we will sometimes use to help stimulate appetite. But I also want to emphasize the importance of not using medications for things like this. And making sure you're talking with, for example, a dietitian about strategies of how you can increase your calories, increase your protein, eating small, frequent meals rather than eating just a couple big meals. A lot of times we have our routines of 3 meals a day, and it's difficult to change that. So I always talk about with anorexia being an issue turning into kind of a grazer, like a cow. They like sit in a field and just chew on something all day. Sometimes that can help patients too. Sometimes food tastes different, and so oftentimes I encourage patients to try new things. Chemotherapy and other treatments can change the way food tastes, and so sometimes you didn't used to like Brussels sprouts, and now you love Brussels sprouts. I wish that would happen to me. It hasn't happened yet. And so those are things to consider. The medications I have up here to stimulate appetite, there's not really strong data for these. They tend to be smaller studies, and there's not always studies in cancer patients specifically. But we do use medications like dronabinol or marinol, which is a THC derivative. So THC is one of the components in marijuana. This agent is a little bit more pure, and there's also data to support its use. But again, I always work on managing side effects if I'm starting an agent like this. There's a steroid agent that's sometimes used called Megace, although there are risks with using steroids in certain situations as well. And then mirtazapine or Remeron, which actually is one of those, if you Google it, it's going to say antidepressant. But one of the side effects is increasing appetite. And then the last one on here is metoclopramide or Reglan. That one I have on here, it doesn't really increase appetite, but it helps in patients who maybe they eat something small and they feel full right away. It can actually increase what we call the gastric transit time, so the time it takes for the food to leave your stomach. And so that's the situation if someone tells me, I eat something, I'm grazing like you say, but I eat a couple almonds and I'm full and I can't eat anything else. That's the time that we would consider something like Reglan. And then sort of the last thing, again, not the last part of supportive care, but the last thing I'll have time to sort of go through quickly are treatment side effects. And so because of the variety of agents we have to treat cancer, specifically squamous cell cancer now, which is great, there's also a variety of treatment side effects that we are managing when we treat our patients. I always tell people, whenever you're starting a drug for cancer, oftentimes the list of side effects can be very overwhelming. And so I always remind people that not everyone gets all of the side effects, and some people don't get any side effects. And so really it's just important that you're communicating with your care team about what you're experiencing during treatment. And so I kind of have it separated out a little bit in traditional chemotherapy. So those would be agents like cisplatin, carboplatin, gemcitabine, paclitaxel. Those are the agents that are really directly toxic to the tumor cells and in some cases can be directly toxic to normal cells. And so the side effects that we manage there are things like nausea, vomiting, things like decreased blood counts, fatigue, the nerve pain that I talked about in the pain management section, and other lab changes. And one that specifically oftentimes people worry about are nausea, vomiting. So what I like to tell people if they have not started on chemotherapy yet is that we're actually getting a lot better at preventing nausea, vomiting. So if you were to talk to someone who received chemotherapy, perhaps even 5 years ago, the medications that we had available to us to manage nausea, vomiting were fewer than what we have today. And we also are using more medications ahead of time, so before you receive the chemotherapy, in order to prevent you from even feeling nauseous. And so I think we're getting better at that. Again, we're being creative. So we're now using things that, for example, were initially developed for, things like depression or other mental disorders. And what we found is that if we change the dose a little bit and change the schedule, they're actually really helpful at preventing things like nausea. And so that's what I wanted to focus on. Fatigue is another one that's very common. And to be honest, that's difficult to manage from a medication standpoint. And so I encourage you, though, to kind of speak to your care team about fatigue with chemotherapy and any of the therapies. There's a lot of non-medication interventions that we often talk about. And so I always tell people that, because some people feel like they just have to kind of grit their teeth and deal with it. But really, if you communicate with us about it, there are a few things that we can help with. And then I think immunotherapies have been discussed a lot so far, so I won't belabor the point. But I do like to talk about immunotherapies have obviously different side effects than the traditional chemotherapy. So things like nausea, vomiting are really very rare with the immunotherapies, which is great. A lot of patients will say that they feel a little bit tired around the time of infusion, or I call them kind of flu-like symptoms, so they might feel a little puny with muscle pain or low-grade fevers. Really what we worry about with the immunotherapy are the autoimmune side effects, which I know we kind of talked about: colitis, dermatitis, hepatitis, and pneumonitis, specifically in our lung cancer patients. In general, most of these are treated with steroids. And so I also want to talk a little bit about that just briefly. So steroids come with some side effects that may require management as well. And so I encourage you to talk with your care team if you're having side effects from the steroids too. Again, anytime we add a medication, communication about what you're experiencing is important. I know I'm running out of time. Targeted therapies. So I know Dr. Pinko presented some slides about looking at the use of targeted therapies in squamous cell, and because our available agents, the mutations that they target, are not as common in squamous cell cancers, lung cancers, we don't see them as much. But I have this slide up here just to remind us that I know Dr. Pinko and other physicians, scientists are developing new targeted therapies for us that will have new side effects, so we'll be managing them. But depending on the target, we can see different side effects. And so, for example, when our target is EGFR, we see this set of side effects. If we see an ALK mutation and we have an ALK therapy, we see a different set of side effects. And so we're learning more every day about how to manage these as we develop new therapies. So kind of to be determined. Dr. Pinko and Dr. Weiss will get to work on that, make more side effects for me to manage. So just in summary, I have this slide just to say communication is really the key to managing. I have up here treatment-related side effects, but I think your cancer care as a whole. And so I always remind patients, never feel like any symptom is too small to talk to us about. I tell patients, if you're having a bad hair day and you want to talk about which hair gel to use, you just give me a call, we'll talk about it. So no symptom is too small. There are often things that we can do that you may not appreciate or know about, and your care team is here to support you through that. So communication is really the big thing.
So I'll lead off the questions about supportive care. One that I feel like I and we have struggled with a little bit is fatigue. Is there anything that you think works?
So there are some things that possibly work. One of the things that I often recommend and start with that there actually is some data for, and I feel like the risk of side effects is rather low, is actually a natural supplement called ginseng. So there is a study looking at the use of specifically American ginseng in cancer patients with fatigue. Now these are not lung cancer patients specifically, and we're getting sort of different treatment modalities. But that study did show some efficacy with the use of ginseng. Now I always caution patients because natural supplements that you can buy over the counter are not regulated by the FDA. And so I ask them to sort of consult with someone before picking a product to ensure that there's quality in the product, and there's some ways that we can help determine that. But ginseng is an option. There's also some data for the use of stimulants that are used in, for example, like patients who have ADHD, the use of stimulants. I'm not sure how beneficial they are, and there are some real risks to using those stimulants, and so I feel like that's really a risk versus benefit discussion. For some patients, they're very beneficial, but again, I'm always balancing the risks of, they can have some cardiovascular side effects, and other issues can come up. But I usually start with things like, exercise can actually really help with fatigue. It seems counterintuitive, but patients who are able to get up and do some walking or do a little bit of exercise generally have less fatigue than patients who cannot. I don't know if anything in your experience has worked.
Unfortunately, not a lot. It's perhaps the symptom that I'm most frustrated that my attempts to alleviate it have not been successful. I think sometimes when we give effective anti-cancer drugs and really suppress the cancer, people feel better, but this is such a cancer-driven process for the most part, the fatigue, that it's a very tough one to actually help.
And I think with traditional chemotherapy, we used to be able to, like was discussed earlier, we used to talk about maybe giving a small dose reduction to help with things like fatigue, but with the newer agents, there's not really good data or information about dose reducing, and we're worried that will compromise the efficacy of the treatment. And so I think that's definitely an area, to think about and focus on. And that's the other thing about supportive care just in general. I think a lot of our research efforts are focused on treating the cancer and curing the cancer. One thing I would encourage, and I think here at UNC, hopefully we'll develop more protocols that are looking at some of these supportive care issues, because I think that's also very important for patients. So doing research into is there something that will help with fatigue that we can do either with a medication or even without a medication. So just like we're still learning about new treatments for the actual cancer, I think we're still learning about new treatments to support patients undergoing cancer treatment. I don't know if I can scroll.
I can scroll. I can now scroll.
Okay.
And I can see that there are no questions at the bottom, but one just came up in the top.
I think the question is probably meant to be, what are the differences in side effects
among the main treatment choices? And so we can I can go back in my slides, right, Akulian?
Yes.
Yeah.
So I kind of tried to summarize the big differences. Now, I didn't list every side effect of the main treatment choices, but in patients who receive traditional chemotherapy, again, we worry more about things like nausea, vomiting, decreased blood counts. Again, the traditional chemotherapy is really targeting, it's not smart enough necessarily to just target the cancer cells, it's targeting any cells that are dividing in the body. And so that's why, other cells that divide quickly, the cancer cells are dividing the quickest, we think. But other cells that can divide quickly are, for example, your bone marrow cells that make new red blood cells and white blood cells, cells in your GI tract, cells in your hair, cells on your skin. And so that's where we see a lot of the side effects from traditional chemotherapy. And it's really based on the fact that traditional chemotherapy targets really any cell that's dividing quickly. Whereas the immune therapies that we're looking at now, they work by sort of ramping up your own immune system to target the therapy. So like Dr. Paco said, the immune therapies really do nothing directly to the cancer. So the side effects we worry about with the immune therapies are really the autoimmune side effects. And those can really happen at any organ in the body. So I have a couple listed here, but essentially we can see those autoimmune side effects anywhere. And again, those would present, sometimes they can present similarly, so changes in lab values. But oftentimes we don't see the nausea, vomiting, we don't see the hair loss that we see with the traditional chemotherapy with immune therapies. And then with the targeted therapies, this was an example, but it's really a mixed bag, and it depends on which target, which specific medication we're talking about. I hope that kind of answers the question.
Okay, I don't have.
Okay. Well,
Well, thanks. That was really wonderful, and a wonderful focus on perhaps the thing we care the most about, how people feel. One side effect that particularly vexes the lung cancer patient, perhaps more than all others, is shortness of breath. The lung cancer patient comes to his or her disease sometimes with pre-existing pulmonary diseases because of the association with smoking. And the cancer, of course, can cause quite a bit of suffering from respiratory complaints as well. And so it's a great pleasure to introduce Dr. Jason Akulian, who's our Director of Interventional Pulmonology here. He's a wizard with a bronchoscope, has really made a lot of my patients feel quite a bit better with some of their respiratory complaints, and a good friend, and it's a pleasure. I'm grateful to have you here.
Thank you for having me. A little quicker. So yes, this is an issue that we routinely see or frequently see in patients with lung cancer, whether it's an acute early presentation or during the chronicity of their disease process. I think some of these new medicines that Dr. Bateman and Dr. Weiss are able to use in the treatment of lung cancer has led to a longer span of life after a diagnosis, and that again leads to seeing patients becoming short of breath during the course of their disease process. I'm going to talk a little bit about the palliation of shortness of breath for patients with non-small cell lung cancer. This sort of includes both adeno as well as the squamous topic. The first part of my talk will be more applicable to the squamous paradigm because squamous cell carcinoma tends to involve the airways more, which can lead to more local regional disease and a clipping off of airways and increased shortness of breath. So I'm going to define interventional pulmonology a little bit, talk about central airway obstruction as well as malignant pleural effusions. I'll also talk a little bit about some of the more sort of just the pulmonology pieces of shortness of breath outside of interventional pulmonology. I don't have too many slides about that, but I'll sort of preface my initial comments with some of those ideas. So interventional pulmonology includes advanced diagnostic bronchoscopy as well as therapeutic bronchoscopy. The thrust of this talk will include therapeutic bronchoscopy as well as the treatment of malignant pleural disease and palliation of shortness of breath due to fluid buildup in the chest cavity between the lung and the chest wall itself, which affects the pressure volume curve of the chest wall, which sends a message to your brain saying, I'm short of breath. It's essentially like being like an asthmatic in the middle of an asthma flare where your chest wall becomes very rigid and you ultimately send a message to your brain saying, I'm short of breath. It's not because you're squeezing down lung and no longer have lung capacity to actually breathe. So it's a little bit of a different paradigm than people actually think. We really use a team approach, and I should include our pharmacy team on this slide. I need to update the slide. But we work very closely with our oncologists, our thoracic surgeons, our radiation oncologists, our ENT physicians, as well as a host of other characters, because this really is a multidisciplinary treatment paradigm in the care of lung cancer. So before I talk a little bit about central airway obstruction, I'm going to talk about some of the things that we have to think about before we even get into the sort of nuts and bolts, hands-on approach of actually opening up an airway or draining away fluid. But rather, when somebody is referred to me because they're short of breath due to their lung cancer or due to something associated with their lung cancer, I have to first put on my pulmonologist hat and make sure that I'm not forgetting things like they might have emphysema or COPD that is flaring in the midst of their treatment. Or if they're on an immune therapy that they're developing a pneumonitis or an infection, right? So it's sometimes very difficult to tell the difference between an infection versus a pneumonitis on just a CAT scan. So we have to think about actually taking a history and talking to the patient and understanding that 90% of all the diagnostics is actually information that the patient will actually tell us. I'm having fevers, I'm having chills, I'm coughing up green stuff, I'm having chest pain when I cough. That makes me think more along the paradigm of somebody having a pneumonia. If they're telling me I'm just short of breath, and we have a CAT scan or a chest x-ray that shows that he has the opacity and they're in the midst of getting their nivolumab or their pembrolizumab, then my paradigm starts to think more along the lines of them potentially having a pneumonitis, right? We have to start to think about that and delineate based on the clinical symptoms and the clinical scenario how best to approach these patients. The other one would be somebody shows up and all of a sudden they have a sudden onset of shortness of breath. So we have to start to think about patients having potentially blood clots. We know that malignancies lead to an increased coagulability, so you're hypercoagulable. You develop blood clots. Those blood clots move from your legs or your deep veins into your pulmonary circulation, which can cause very acute and sudden shortness of breath, as well as sometimes life-threatening levels of low oxygen. So we have to keep all of these things in mind when we initially see these patients, sort of try to understand, all told, why they might be short of breath. Another potential cause of shortness of breath is pain. Right? So Amber did a beautiful job talking about how she manages pain and the acute pain stresses and chronic pain stresses associated with malignancy. But oftentimes patients will have enough pain that they actually become short of breath. And when you alleviate the pain, all of a sudden their shortness of breath diminishes greatly, or even potentially goes away completely. Anxiety is another piece of this, right? So people who have a chronic disease and when associated with cancer, people become, they have anxiety associated with cancer. Even when they're nearing the end of their life, they can develop anxiety surrounding some of these issues. And sometimes it's as simple as anxiety is driving shortness of breath, and something that we have to keep in the back of our mind. That's oftentimes a diagnosis of exclusion, meaning we've kind of gone through all of the other potential life-threatening things that could be happening, or things that are deleterious to one's life, the morbid conditions. And then if we really have nothing else in our bag, we really need to explore that anxiety component potentially. But again, that's certainly not the first thing that we go to. So I'll talk a little bit about the first piece of my actual slides, and that's central airway obstruction, which prior to that paradigm flip that Dr. Paco talked about with the advent of filtered cigarettes, when patients were having much more in the way of central airway obstruction due to squamous cell carcinoma being the predominant lung malignancy being seen. When you have a disease process that's more central and involves larger airways, then you certainly can develop a large airway obstruction from those tumors. The symptoms really depend on the cause and what are the comorbid conditions the patient may have. Do they have heart failure? Do they have COPD? Do they have previous lung fibrosis from radiation that was given to them? And so understanding the global who the patient is, rather than just sort of the piecemeal pieces of who the patient are, will help guide and help us understand what may be driving their symptoms. Central airway obstruction may become rapid or may be gradual. Although cancer grows gradually, there are certain cut points that we think about where patients can become acutely short of breath. Patients oftentimes, when they first show up and maybe don't have a diagnosis, but they may have had a tumor that's growing in their airway long enough, they may develop a wheeze, and oftentimes would be misdiagnosed for weeks or potentially even months until somebody actually gets the proper imaging. They're sometimes given bronchodilators or steroids, and somebody actually listens to their chest and says, wait a minute, the wheeze is only in one place, right? So the wheeze, if you have asthma or COPD, is global throughout the lung field. If you have an airway obstruction, it's local. You may have exacerbations of infection, or you may even result in infection. So once you start to close off airways, you don't have that natural clearance of your mucus and the natural clearance of the bacteria that develop in all of our lungs. Our lungs are not a sterile place. We inhale all the bacteria on the planet into our lungs. Some of it lives there and doesn't do anything, and some of it goes down there and causes infection. If you're not able to clear out those infectious organisms and develop a high bacterial load, you can then develop infection or exacerbate an already present infection. Those cut points that I talked about, so people develop shortness of breath on exertion when the airway is dropped below 8 millimeters in size. So the average trachea is between 16 and 22 millimeters. The average right mainstem bronchus is somewhere between 8 and 10 millimeters, so really right about 10 millimeters, and the average left mainstem bronchus is 12 millimeters. So when you cut those, when you get below 8 millimeters, you actually develop shortness of breath on exertion. When you develop an airway that is less than 5 millimeters, you actually develop stridor that you can hear. And that potentially can be a life-threatening situation if it involves the trachea. And then finally, patients can show up just with respiratory distress from the onset. Approximately 20 to 30% of patients with malignancy and with lung cancer will develop central airway obstruction during the course of their disease process. 40% of deaths are historically due to this local regional occurrence and progression. Other diseases that are metastatic to the airway include this list of cancers. And what is the initial workup? So when a patient first comes and sees their physician due to shortness of breath, they'll often get a chest x-ray. Oftentimes they'll just skip straight to a CT in today's world of medical technology. Some of these CTs actually have a dedicated airway protocol where they can do a 3D rendering to understand where the cut point or where the stenosis actually lies within the airway. And some of these techniques actually offer help in procedural planning. So if the patient does have a narrowed airway and you can develop 3D reconstruction, you can have a better understanding about where in the airway there might be an issue. And they can also be used for non-invasive follow-up once you've alleviated the obstruction. Rigid bronchoscopy is now becoming the mainstay in how we deal with airway obstruction. It's actually an old technology. It was first performed in 1898 by Akulian. This is a picture of Dr. Akulian actually looking down a patient's airway who was awake and topicalized with cocaine. We don't do that anymore. We actually put you to sleep, and you're not aware of these things happening. So this is an old picture, but that's really how they used to do it. You can actually oxygenate and ventilate through a rigid bronchoscope. You can use large bore suction. You can use the scope to actually dilate. You can use a myriad of tools to then open up the airway and help patients breathe. These are some of those interventions that you can actually perform. You can use lasers and electric cautery. You can use an argon plasma coagulator. You can actually send the laser down to use what's called photodynamic therapy, where you use a photophore that's injected 48 hours prior to the procedure. It's then taken up by the cancer cells. It emits, the laser emits a certain wavelength of light that causes oxygen-free radical formation and actual cell death of the tumor itself. It's safe within the airways, though, because normal tissues do not take up the drug in the same way that tumor cells do. You know, we can use cryotherapy. We can actually freeze tumors. We can use a microdebrider, which is a small spinning blade attached to a suction that actually cuts the tumor open. We can put in stents, and we can even potentially send these patients on to surgery once we've alleviated their shortness of breath and brought their performance status to a level where they can tolerate surgery. We certainly work closely with our radiation oncology colleagues in that radiation in these situations is what we consider definitive. So the rigid bronchoscopy and opening of the airway is not definitive. It's an acute relief of shortness of breath. Sometimes the stent can be definitive, but oftentimes if patients are able to receive radiation, we'll send them on to our radiation oncology colleagues once they've had their airway opened. The disadvantages and the reason why this works in such contrast, or I shouldn't say contrast, but in concert with rigid bronchoscopy is that radiation takes some time to actually work. So sometime between 2 to 4 weeks for the radiation to actually sort of kick in and start actually causing cell death. In addition, in the short interval, so in the week or two leading up to actual cell death, radiation can actually make things worse, and that they'll cause swelling of the tumor in the tissues and worsen the airway closure. But we can actually remove the tumor from the airway and then definitively treat the area that we can't get to outside of the airway. That's the best possible scenario. We often will place stents in patients who have a recurrence of their cancer once we removed it from the airway despite radiation. So if we can remove it and give them radiation, we won't put a stent in immediately unless we need to. And this can oftentimes sort of be a game time decision. The perfect stent would be easy to place. It would maintain airway patency. It would adapt to the dynamics of the airway. We don't think about it, but our lungs are extremely dynamic. They're constantly moving. There would be no high pressure points. The stents would press on anything they shouldn't press on. They cause no granulation or inflammatory tissue at the front or back end of it. They never move except if we wanted them to. Have secretions that would build up in them. They'd be easy to remove, and they come in every shape and size we wanted to, and they'd be cheap. Clearly, our stents don't fit these things. They are useful, but they clearly have their issues. When we look at outcomes, right, so people have actually looked at this, because oftentimes central airway obstruction becomes sort of a nihilistic paradigm, where people say, oh, the tumor's getting big, it's pressing on an airway, we really don't have much to offer you. And I would counter that that's actually not true. So there have been a number of studies that have actually looked at patients who've been intubated actually for respiratory failure or distress due to their central airway obstruction. They then went and removed that obstruction and were able to show that these patients can be successfully extubated afterwards. They actually showed that those patients that weren't intubated but they were in distress, 71% of them were able to have a reduction in level of care. So they were able to come out of the ICU or come out of the step-down unit down to the floor and became stabilized. They also showed that mortality was dependent on the success of the airway intervention. So if you're able to open the airway, patients actually lived longer and suffered less. And the suffered less will be on the next slide. slide after this. So another study looked at, it was a small retrospective study that looked at 12 patients. All of them had been intubated and ventilated because they had inoperable or unresectable central airway obstruction due to non-small cell lung cancer. 91% of them had their airway patency restored. 3/4 of them were immediately extubated or removed from mechanical ventilation. The median survival was 228 days. And if they were extubated within 24 hours after the procedure, the median survival increased to 313 days. So again, it's a powerful way to decrease death from suffocation, which is probably the worst way to die if you're headed in that direction. The next question was, okay, so you can remove these tumors, get them off the ventilator, and you can make them live longer. But again, do they have a quality life? Are you just sort of prolonging people's lives, but having them just suffer being short of breath for that entire period of time? So this is a Danish study where they actually looked at this, and they showed that patients who received airway stents lived a mean of 11 more weeks. They had no prolongation in suffering. 80% of them were actually able to pass at home, and the majority who passed of non-respiratory causes, right? So they're not just sitting there suffering as you extend their lives, but actually you're palliating their shortness of breath. You're making them feel better in the last days that they may have. They also show that patients with central airway obstruction treated with rigid bronchoscopy and standard care had similar outcomes to those who never had an obstruction. And so again, if we're not prolonging suffering, we're prolonging life and improving how people actually feel. In another study, they looked at 36 patients who underwent an emergency airway intervention. They showed that they relieved shortness of breath in over 90% of those patients. More than 60% of them went on to have an additional definitive therapy. The patients who had the additional definitive therapy had significantly longer survival, 38 months versus 6 months. But finally, I alluded to the fact that if we're able to actually make you feel better and look better to the surgeons, they can potentially do curative surgery. So there was a very interesting study. This comes out of Boston, where they looked at 74 patients who had resectable disease but presented in a way that they were not able to perform surgery on them due to their dyspnea. And they showed that once they removed their airway obstruction, their forced vital capacity at 1 second, their forced expiratory volume at 1 second increased from just under 2 liters to over 2 liters. And of these patients, more than 50% of them were able to undergo curative resection. Switching gears and looking at malignant pleural effusions or fluid around the lung, this is actually more commonly seen in our practice than central airway obstruction. We see a large number of patients present to us with advanced stage cancer that has metastasized to the pleural space and is causing recurrent buildup of pleural effusion. We know that the second leading cause of malignant effusions is cancer. The second leading cause of exudative effusions is malignant effusions, over 200,000 per year in the United States alone. Similar numbers in Europe and across Asia. 75% of these due to lung, breast, and lymphoma, with the bulk of them actually being lung. Most commonly, people present with shortness of breath. And again, this is due to that alteration in the pressure volume curve of the chest wall. The chest wall becomes rigid. It's a closed space. If you dump a bunch of fluid into your chest, all of a sudden that chest wall becomes rigid. You don't have the natural swing with each breath, and you become incredibly short of breath. People can show up with cough, some dull chest pain, some weight loss, fevers, and about 25% of them are noticed during the initial workup and are asymptomatic, but will oftentimes progress to symptoms. So we have to think about these patients with advanced stage lung cancer as people that we don't want to overly proceduralize, because again, then we're starting to add morbidity from the procedures that we're actually performing on them and taking away the quality of their life when they're as short of breath as they are and with the advancement of their cancer. So we like to palliate them early. We'd like to have them have no further shortness of breath, and we'd like to do no further intervention if we don't need to. We don't want people to keep coming back to the doctor as they're short of breath from their cancer because they're short of breath. We'd like to get rid of that factor and let them live their life and enjoy the rest of their life instead of being short of breath all the time. So some of these palliative options are oxygen and morphine, observation if patients are asymptomatic, repeated thoracentesis or drainage with a catheter that is then removed at the end of the procedure. It shows that it does relieve dyspnea or shortness of breath if you perform a therapeutic thoracentesis. Typically, about 100% of those patients recur at 1 month. Now, that's changing a little bit. There's a little bit of old data that's actually changing a little bit with some of these new medicines that we're seeing that is actually decreasing the recurrence of the pleural effusion. There isn't good data out with the new drugs yet that's looking at recurrence rates of pleural effusion, but anecdotally, I can tell you that we're seeing this where we'll drain the patient, they'll get put on a targeted therapy, and they won't come back for a while. And potentially that they may develop a resistance mutation, and that may recur. There may be some sort of a clonal expansion outside of their pleural space, and they may not have more fluid building up. And so there is some variability now that we're seeing, and I think that's an interesting area potentially of research. Oftentimes, chemotherapy will be given as an attempt to get rid of the pleural effusion. We like to drain the effusion first, as there are some chemotherapies that are known or that have been associated with toxicities and that they build up in the pleural space. People have tried intrapleural chemotherapy, where they actually inject chemotherapy into the pleural space to try to kill. There are a couple of interesting studies where they were small case series studies where they showed some interesting results and then sort of went away. So I don't actually know what happened with those patients longitudinally, whether everybody sort of lit on fire or what happened, I'm not really sure. But it's something to potentially explore down the road. More interestingly, with immunotherapy, I think, far more than cytotoxic chemotherapy in the pleural space. You can, at times, give radiotherapy. And then the real mainstays of treatment right now are pleurodesis, which is installation of a sclerosing material, something that scars the pleural space, to get the lung to stick up to the chest wall and actually obliterate the space where the fluid occurs, or a replacement of a tunnel pleural catheter for drainage at home and serial drainage, where you can actually achieve spontaneous pleurodesis in some cases. So this is what the tunnel pleural catheter looks like. It's a fenestrated silicone catheter that's inserted through the chest wall and tunneled under the skin into the pleural cavity. The little white cap at the end can be accessed and attached to a drainage bottle where patients are able to drain at intervals of sometimes every other day, every 3 or 4 days, and they're actually able to drain and relieve their dyspnea at home. The next question is, does it work? So Dr. Tremblay actually studied this first in 2006. They placed 250 catheters in over 200 patients, and they had complete or partial symptom control in almost 90% of patients. The catheter duration that was left in place was approximately 56 days, so I often have patients ask me, how long does the catheter stay in? And the answer is, it could stay in for the duration of life, but we can also oftentimes take it out due to the achievement of pleurodesis in patients where the lung and the chest wall stick together and the space is obliterated and no more fluid accumulates. We can develop spontaneous pleurodesis. The 42% or 43% was actually all comers, so that was everybody from people who had heart failure, people who had breast cancer, and everybody in between. Breast cancer seemed to spontaneously pleurodese faster than, or at a higher rate than anybody else, probably because of the inflammatory nature of breast cancer. Lung cancer pleurodesis spontaneously right at the 50% mark. They were able to show that there were no further interventions, and this goes back to that Holy Grail slide, in 90% of patients, right? So the catheter was placed, and patients did not require further intervention for their shortness of breath in 90% of those cases. And then the risk of infection, while present, was quite low. So it's an acceptable risk when you're able to palliate somebody from their shortness of breath due to their recurrent pleural effusion. And this is one of the mainstays of how we actually care for patients. We know that installation of a sclerosing agent, a scarring agent, doesn't work if your lung doesn't fully re-expand. And oftentimes in lung cancer, due to the inflammatory nature of lung cancer and the immunobiology, the immune system actually attacking the cancer, you develop scar around the lung, and that actually inhibits the lung from expanding even when you drain that fluid out. Thereby, if you put some kind of a scarring mechanism in there, nothing's going to scar. It's just going to sort of swirl around in there and potentially cause its own set of problems. That's what I have to say about the palliation of shortness of breath in patients with lung cancer. It's question time. Apparently nobody's asking any questions.
Actually, no, they are. We've got them.
They are. I have them on smartphone too, because the scrolling was an issue. Let's pull these up. So someone had asked if all of our presenters at Lineberger are this attractive. It was someone in the room. Thanks, although no thanks for asking it during Jason's talk. And
wise question asker.
But there were some here that we haven't addressed yet. One is, I've been living with this disease for 4 years. How are doctors currently treating long-term cases like mine? That's actually a tough question in a lot of ways to think about how to get at that. So, I think there are lung cancers that have some kind of unique biology that no matter what we do, it works. And I think they do require a change in our thinking a little bit. For a patient with a shorter prognosis to their life, we often put first do no harm as our first principle. So we might stop, for example, drugs like statins that treat high cholesterol because it doesn't make common sense to have the risk of the muscle aches and problems that they come in if life expectancy is shorter than the range over which a patient might be expected to have a heart attack. And there are other examples of this, for example, like rigorous blood pressure control that might not make sense just from a simple human standpoint that make a lot more sense in a patient with a longer prognosis. So I think it's kind of the opposite of the roadrunner, right? The roadrunner realizes he's not supposed to be still doing okay over the edge, and then that's when he falls. This is kind of the opposite. Getting to longer than you're supposed to by the statistics is a good predictor of doing yet further better and further better. So I think we do shift our perspective more towards the long term. I think people like Dr. Peko like to sequence these patients and try to understand why. Frankly, clinicians like me like to do that too, because we're doing it with the goal of saying, is there something unique here that I can use as well as a future option? And I think the final thing from a medical oncology perspective is that we'll get a little bit more out of the box, a little bit more comfortably with our therapeutics, so that if we get done with the list of therapeutics that are typically associated and typically used in lung cancer, we'll go back to an older historic literature and say, okay, what's been proven to at least be active? There are some tumors that their biology is just such that any active lung cancer drug that you throw at them, it's going to work for a time. And so we sometimes string together longer and longer survival through serial use of what might be called old school agents in these kinds of cases.
And I would add to that I think he's right. This challenges us because it actually changes the way that we have to think about these patients, and we have to start to think of them a little more holistically outside of their actual cancer. And so, again, Dr. Weiss made reference to the idea of we would normally potentially stop a statin, but maybe some of these patients need a statin to continue on because their life expectancy is changing in a way that we're not expecting. I think we're sort of at the peak of this iceberg, and we're trying to understand what's under the water, especially with these targeted agents and the immune therapy that we're using. It's really starting to change the way that we think about the long-term treatment of these patients.
Somebody asked about what the best chemo is to try later when there's progression on immunotherapy. This depends on what's been given before. So I think I probably picked up okay here, but the question was about chemo after immuno. You basically look at what hasn't been used thus far, pretending immunotherapy hadn't yet been invented. So if someone got immuno as their first treatment, then we use the same platinum doublet you would have used after that. In my practice, I like carboplatin and Abraxane, but there are plenty of reasonable doublets to be used. The person had gotten such a doublet, then get second-line agents such as, say, nivolumab, then you go to whatever you otherwise you would have used in second-line. The standard of care is often listed as docetaxel. We're late in the day, and I'm getting tired, so I'll editorialize and admit that's not an agent. I often go out of the box on this and avoid it because of its toxicity, and might use drugs that are known active, but you know how to stop that great. That are not necessarily approved in second line, but that are a little bit gentler drugs like gemcitabine or one of the other taxanes. Just see what else have folks asked. What can be done at home to help a patient fight their cancer?
Apparently, this doesn't happen very often. It's probably a telemarketer, most likely, because this is North Carolina and it's
Well, I've
probably
already
a
voted
pollster.
early, so if you're
you're telemarketing me in while to be learning about lung cancer, vote for immunotherapy because it actually works, unlike much of our political system. So what can be done? What can be done at home to? That's actually being broadcasted during content. You know, what can be done at home to help a patient fight their cancer? That's another broad philosophic question.
Right. I think it's everything from family support and a good network, good support network. I mean, I think trying to keep a positive attitude. I think proper nutrition. I think Mom always told us eat our apples and get our sleep, and I think that's still good advice. I think the body, when it's fighting any kind of an illness, needs proper convalescence. I also would say in the same paradigm that we don't want you sitting around and laying around on the couch and losing muscle mass and losing energy. Amber made the comment that patients who exercise more have more energy, and I think that's the old Sir Isaac Newton said things that stay in motion or are in motion tend to stay in motion, things at rest tend to stay at rest. I'm a little paraphrasing for him.
And at 4 p.m. on a Friday afternoon at our appointed end time, that might be a time for a lot of us to get to rest. So I'd like to again thank our speakers. And the generous support from BMS, Celgene, and Genentech. I'd also like to again thank the Lung Cancer Initiative of North Carolina, Cancer Grace, and Lineberger Cancer Center.